too many things going on. I can't get it all. Let's see. There's a laser. There it is. Laser. That's not a laser. Spotlight. Now it's a laser. Okay. The main lobar fissure, this line right here, we don't often see it, but you can see that the gallbladder is kind of sitting right in there. We have just a cut off portion of the main of the portal vein. It's actually, I almost said main portal vein. Oh my gosh, I can't think of my anatomy. But all right, so portal vein, and then common bile duct, always anterior to the portal vein. There's a hepatic artery in here, but it's a lot smaller. A lot smaller. Not only is the hepatic artery taking a lot less blood into the liver, but arteries are generally smaller than veins anyway. So here's more of a stylized picture, and we have the Mickey Mouse sign here. So not really seen up here, but Mickey Mouse sign of the common bile duct on our left as we're facing here, and hepatic artery over here. So portal triad. This gallbladder, there's a couple things going on here. Well, one, we have a Frisian cap. The Frisian cap. So we see what appears to, oh, it's right too. Oh, cool. And it doesn't go away. Anyway, until I get this fixed, the Frisian cap can look like a septum, but if you know where things are and the folding that oftentimes goes on at the fundus of the liver, or the gallbladder, we'll know that this is a Frisian cap. Remember, stones can get stuck up in here. So here's the body of the gallbladder, and down here in the neck. And this neck, I don't know honestly if this truly is a Hartmann's pouch, or if I would characterize it truly as a Hartmann's pouch, but it's pretty darn close. The neck goes around, turns around the corner here, creating another almost pseudo septum, but that's just a fold here. On this gallbladder, boy, I would not be comfortable putting my calipers down. I'm not sure where the wall is, or where the wall ends on this anterior portion. So, and this is a case where I might measure the posterior wall, or maybe measure the wall across here, even though we're supposed to do AP. Maybe I could do an AP from here to here. Clear all drawings. That's not working either. Let's get out of that entirely. Okay, at least it's stuck only on that slide, so I'm not going to worry about it. So I will take my laser back. Okay. Although, all right, actually after this slide, I'm going to ditch the laser because it takes my ability to, oh no, I can still change things. Okay, sorry guys, I'm slightly distracted today. Here, just a couple of pictures. Here, we can see this hepatic artery, the circle, and that's actually the right branch of the hepatic artery. So what's going on here is there's a branch going off this direction and then that direction. I read in the book, and it just made a quick reference, that when the hepatic artery is anterior to the bile duct, it said a replaced hepatic artery. I never knew that. And I'm going to do some research on that and see if they mean replaced as in just a different spot, or if a replaced artery. Remember, when we go all the way back, a replaced right hepatic artery is one that comes up separately from perhaps the SMA, which is not normal, or as my student from last semester, she had a replaced hepatic artery coming straight up from the aorta. So that was an interesting thing I never knew before. And I still don't know if it's correct, but we have a bile duct going. It's oftentimes a little thicker on this side of the hepatic artery and a little thinner on that side. And kind of makes sense, like the hepatic artery is kind of squeezing it out a little bit. Main portal vein, and at this particular location, they're on top of the IVC. The IVC and main portal vein are not traveling quite in the same direction. The IVC is going straight back to the heart, and this guy's going straight over here to the liver. But from this picture, they kind of look like they're running parallel. And then we have another nice, beautiful image down here of oh, interesting, a gallbladder. I hadn't even noticed this before. Nice common bile duct, beautiful common bile duct. Portal vein here, I guess that's a hepatic artery right there. It's a, kind of going into, right when we get into the liver, it's already splitting. And you can see from this picture, by the way, how the gallbladder is not in the liver. The liver is on top, not behind. There are plenty of images that makes the gallbladder look like it's in the liver, and Melissa is very big on getting these pictures where we're not making it look like the gallbladder's in. I didn't even notice it before, but if you look closely, that's a very thick wall on the anterior surface. And I would measure, oh, I guess I could write on this. Oh God. Just can't win. Well, okay, I'm pointing to the middle of the wall right there. And the hypoechoic line, see that really thin hypoechoic line? I would be taking a very close look at that if this were my patient. If there is a line, a hypoechoic line around the outside of a thickened wall, that could be pericholecystic fluid, and that is a clear indication of cholecystitis. This wall thickening is also an indication of cholecystitis. Okay. Cystic duct is often not seen, although here we actually do see it. We have the spiral valves of Heister. This is just a pretty decent sized cystic duct, or it's just really good imaging quality. But so the neck of the gallbladder is down here, and then as it turns around, there's that cystic duct. Over here again, some spiral valves and another cystic duct going around here. So fundus, body, neck, wall. As best as I could see, this wall is normal. Septate and multiseptate. So this appears to be more of a true septation. The other thing the gallbladder can do is fold, and just and just like a Hartmann's pouch or a Frisian cap, it can fold in other locations and create kind of the same thing. And I don't think this is a fold though, because that gallbladder overall is pretty much gallbladder shaped. So this does seem to be a single septation. Over here we have some multiseptates. Man, I wish I had a picture of the one I found, because it was the most epic ever. Nice thin multiseptations on this person, and this one, some more multiseptations. I could only assume, guys, that there is communication between the bile here to here to here and all and out. If not, this would be there would be a lot of problems, and if there's stasis of bile inside of a gallbladder, you know, very thick sludge form, stones form, probably cholecystitis eventually. Notice the gallbladder wall on, you know, it always looks different. Like this one up here, really thin, really thin. This one, okay, not so thin. I don't think it's not beyond 3 millimeters, but I would measure up and down right here is where I would take a measurement on that. Oh, and the other thing is actually, different doctors will tell you different things. Most of them will tell you you want to measure the wall in transverse, but some of them don't care. And I've even had some say, no, I disagree with that, measure it in long. But I believe most of them will say transverse measurement. Like, whoop, never mind, I was going to say that's a transverse measurement. But no, that is actually not gallbladder here. This is a choledochal cyst. Let's see, on this one is impinging, having a mass effect on the gallbladder here. CC, choledochal cyst, CC. But don't ask me what pH stands for. Another cyst over here. This one appears to be a little more outside. So gallbladder, liver edge over here, big cyst, and VP. Oh, let's see, the pancreas. Well, the pancreas. Let's see, the aorta down here. SMA. Oh, actually, this fluid right here. That should be about where the confluence is, I believe. I'm not 100% sure that's the confluence, but that's about where it would be, because we do have a pancreatic head right about there. It's actually being pushed over, because normally you don't see the pancreatic head. This is the uncinate process. At least I am thinking it is. It's not totally clear to me. The uncinate process is anterior to the superior mesenteric artery. That's pretty unusual. But anyway, moving right along. Carolese disease. So that's another, these are choledochal cysts as well, but it's the only one that has its own name. Named after Carol. No, Dr. Caroli. And these are communicating. You see how they're all communicating, but they will also communicate with the common bile duct eventually as it heads out. These are all intrahepatic communicating cysts. Intrahepatic communicating. Yeah, could not find even close to an interposition image on ultrasound. So I took this image instead, which is kind of cool. Gallbladder. That's by the way, if we could see this on ultrasound, we see a nice gallbladder fold. This gallbladder is folded over on itself. And so we would actually see a pseudo septum right here if this were ultrasound. But we can clearly see like a right, and I assume this is right and left hepatic ducts, and no common hepatic duct that goes straight into the common bile duct. Oh, look, and you could actually see, you can't see organs. 5 centimeters, okay. You can't see organs too much on this X-ray here. It's an X-ray with it's an X-ray with contrast. But anyway, this right there, that has got to be, could only be one thing. That's the pancreatic duct coming into the common bile duct. This has got to be the ampulla of Vater, and the sphincter of Oddi would be little muscles around here, and then it goes into the duodenum. It's actually the major papilla. I didn't mention that the other day. The major papilla is the opening into the duodenum. So we've got some sludge images. This is a nice kind of a fluid level here. So this sludge is, you roll this person, it's gonna slosh on over like an old lava lamp there. That's a pretty round gallbladder, and it's hard to say exactly how big this is, but I'm thinking this is big. So this is a transverse picture. They took their wall measurement in transverse. The wall looks normal. Wall looks completely normal, but this is a big gallbladder. I'm thinking this gallbladder it's called hydropic. We'll talk about that today when it's large like that. Pretty cool. Here's more sludge or possibly pus. This is kind of a funny looking sludge. It's my air compressor going off, if you could hear that. Forgot that was on. Hepatization.
Yeah, real quick before we jump into this, on the slide before when you were saying that that could be pus or sludge, does sludge normally? Well, I guess so. Yeah, if it's right there on the left, my bad. I guess it does give it a more echogenic look to it.
It is, and the thickness of the sludge. And what the sludge is made of. There's actually echogenic sludge. There's extremely echogenic sludge. The book goes over that, but I will. It's milk of calcium sludge, but usually it's about that consistency on the left-hand side. So on the right, that could be tumefactive sludge, and all tumefactive sludge means is that it looks like a tumor, and it's not, but it just looks like it is. So, hepatization. I usually say it with too many syllables. Hepatization. There's a couple of nice examples of hepatization on this one. You can see there's a gallbladder here, but from another angle, you're looking at this, and like an angle where the liver seems to be surrounding the gallbladder, it might really be hard to see. So all hepatization means is that the sludge happens to be the same echo texture as the liver. Same thing over here. That probably is a thickened wall. Wall doesn't look great, but not 100% sure it's thickened, but it certainly kind of looks like that. Tumefactive sludge. Well, see, that looks like the same sludge as the other ones. So tumefactive simply looks like a tumor. Both of these, especially this one actually, would definitely give me pause. They call it tumefactive because it looks like a tumor. And so if I saw this, the first thing I would be doing is throwing Doppler on that. I want to make sure that if there's blood flow in there, then it's not sludge, it's a tumor. Same thing over here. But, and once again, this is tricky. Very tricky on where you decide to put your calipers on this one. I don't personally believe that because you can get focal thickening, the thickening of the wall doesn't have to be everywhere. I personally don't believe that's thickening. I think we're seeing gallbladder wall and surrounding pericholecystic fat and connective tissue. So that's tricky. Like this one's not tricky. I can clearly see where to put my calipers. This one, see how this is this is clearly, Mickey Mouse sign here. Let's see, duct, hepatic artery, portal, surrounded by echogenic Glisson's capsule, and you see how it's kind of continuous up here. So I think I would probably put my caliper measurements certainly away from this junk up here and put it up here. I have in the past, especially when I simply can't get, like, there's too much reverb artifact sometimes. Yeah, I just can't see. I can't confidently see the wall thickness here. I'll take it down here. I'll take it on the backside. Now on this person, I can't see the backside very clearly. Doctors generally don't want you to take it back here. Personally, I see no reason why not to. And so I try to always do it up here, but if I simply can't, I take it down here. No one's ever complained. They probably see what's going on. Sludge Balls and Spaceballs. Greatest movie of all time. Sludge Ball, this is pretty cool looking. Once again, I'm not measuring this part of the wall. I don't think that's all wall. You know, if it is, it is, but I don't think it is. Certainly with a very thin wall up here. This is a really famous image because it's literally, I don't know if they did it on purpose. Someone was able to manage to balance a sludge ball on top of a triangular stone, which is really cool. And this sludge ball as well. This one's got a little bit of hole in it, but yeah, if it's a sludge ball, it's a sludge ball. It's not the end of the world. Okay. I just grabbed this picture simply because, this is the biggest reason. Pericholecystic fat, gallbladder wall. All right. On this one, I am measuring. It's not going to stand. I'm going to measure this from here to here. Okay. I've seen, and it's not their fault, it's just people don't realize. I've seen plenty of people measure from here to here. That's cholecystitis. That's a normal wall. So huge difference there. What else do I want to say? But however, we don't always see this difference. We don't always see this pericholecystic fat separate from a gallbladder wall. And I'll show you some images about that. Sometimes you do, you just measure everything you see. Other times, like in this situation, you do not measure this, you only measure that. And if anyone gives you trouble, have them talk to me, because people do measure this incorrectly. Sludge stones, acoustic shadowing off of that. The stone formerly known as sludge ball. So this definitely looks kind of like a little sludge ball. Look at that. There is shadowing. As soon as it starts causing shadowing, it's a stone. So, and I was, oh gosh, so many times where I've been embarrassed in my life. So I have this one radiologist I used to work with. I disliked him intensely, and I think he was a smart guy, but wasn't a very good radiologist. He wasn't. He made a lot of mistakes in any case, and so I always prided myself on finding his mistakes. And unfortunately, one day he found my mistake, and because I had this patient say, he tells me, oh, just so you know, I have gallstones. I'm like, oh, okay, cool. And I do a scan, and sure enough, very echogenic, circular structures, movable inside the gallbladder. And I said, oh yeah, you do have stones. And I wrote it down, stones, and I get a phone call from this doctor. He says, Kurt, do you see shadows behind those? And I went, oh. I said, no. He says, yeah, that's right, and hung up the phone. He's such an ass, but he was right. I was distracted. I was told by the patient that he had stones. He clearly had something very echogenic rolling around in his gallbladder, and I said, stone. It wasn't. There was no shadowing behind it. It was just super echogenic. So he was told, obviously, someone else made the mistake, and then I followed up on the mistake and added to it. Let's see. Yeah, we did talk about this. The wall, echo, shadow. This is kind of cool. And so you have, well, identifying a measurable wall is oftentimes pretty hard because you might see the outside, but gosh, where exactly does the inside start? So, you know, I could think to measure from here to here, but very difficult. And if you can't do it, you can't do it. But um, this is dark shadowing, wall, echo, shadow. Same thing over here. Here, I might be able to measure this wall a little better on that guy. Not to be confused with the similar wall echo shadow of air in the gallbladder, and basically emphysema of the gallbladder. When air is in here, it looks like wall echo, dirty shadow. And so that's the difference. That's how you know. A dark shadow is going to be gallstones. Dirty shadowing is from air. Okay, this is new. All right, here's new stuff. Acute cholecystitis. There's nothing cute about it. Which reminds me of a dirty joke, but we're not. We are recording, right? Yeah, you told me to record. 95% of acute cholecystitis cases come from impacted stones. We have clearly have stones, not terribly echogenic stones, kind of weird, but they have shadowing. So we are going to call this gallstone. That there's actually, see that little comet tail, another comet tail, that's actually cholesterol stuck up in the wall of the gallbladder. So that's another disease process possibly, but we'll talk about that later. Pericholecystic fluid, look how very thin line, but that's all it takes to be pericholecystic fluid. We want to pay attention to thin black lines on the outside of the gallbladder wall. Definite wall thickening over here. This one, and they measured here, but look at over here. They could have measured this one across like that and got even bigger measurement, but you know, they decided to go with the AP measurement, which is good. Fluid inside the wall. See this? This is wall from here to here, a little shadow and stone. This is wall from here to here, but we have edema. See, when it's outside the wall, we call it fluid. When it's inside the wall, we call it edema. So there's edema inside of this wall. Now let's see, inflammation, necrosis, ulceration. Ulceration means a hole has developed in the wall. It doesn't have to be there, but inflammation has to be there. Necrosis may or may not be there. Ulceration may or may not be there. Thickening is almost always going to be involved with acute cholecystitis. Hydropic, that once again, that means it's enlarged. The entire gallbladder is enlarged. And your liver function tests are going to be increased there. So that's acute cholecystitis. So hydropic, this is actually what I was just texting, texting Melissa on what her number is for hydropic. I was taught that the most important measurement is the length, but I was taught incorrectly. Actually, the most important measurement is across, probably lumen, yeah, lumen only. Oh no. Yeah, lumen only. Cross, if it's greater than 5 centimeters, it is hydropic. You know, considering this is a 5-year-old, that pediatrics have different numbers. 5 is for adult. 5-year-old, this is still hydropic, even though it says 4 centimeters. And a wall is edematous. I don't know, I guess if they're calling that edema down here. Yeah, I'm not so sure about edematous wall, but yeah. So I grabbed this picture specifically because I should have put it up higher in this PowerPoint, but see, it's just a thin echo. We're gonna measure the whole echo here, and that's obviously very thin. That's probably not even 2 millimeters thick. But we'll measure this whole echo here on this person. Let's see if I do a little more AP. Sorry, I cannot draw a straight line to save my life with this pad here. Okay, well, all right, close enough. I'm measuring, looks like that's the end of the wall to the end of the wall, and that is Glissen's capsule up here, so we don't want to measure that. Okay. A markedly thickened wall. That's really not a happy gallbladder, but this would be probably acute cholecystitis. The edema inside of the wall, there's fluid inside of the wall. Same thing over here. And I'm even seeing sloughing, which is kind of weird. Possible, just I'm looking at the inside of the wall, and it looks like it might almost be peeling off just slightly. So that could be indication of like necrosis, stuff sloughing off here, but certainly thickened wall all around. Before we get into A calculus, let me just make sure. So acute cholecystitis, 95% caused by impacted stones, inflammation, necrosis, ulceration, swelling. Well, of course, there's going to be a positive Murphy sign, sonographic Murphy sign. That means when you push on the gallbladder with your transducer and the patient screams bloody murder, that's a positive Murphy sign. Nausea, vomiting, fever. This is bacterial. This is it's probably bacterial infection in here, and so that's going to get into the bloodstream. That's going to cause an over global reaction. So you have fever. That means also you're probably going to have increased white blood cell count. So white blood cells go up. Jaundice, obstructive jaundice, because probably it's an obstructive process to begin with. LFTs, pericocystic fluid hydropathy, really thick wall. Okay. So acalculous cholecystitis, we don't always have to have stones. So if the other one is 95%, this is about 5% or slightly more. Total parenteral nutrition, I have a hard time saying that word, sorry. TPN, in other words, they're being fed via a venous catheter. Severe burns will cause cholecystitis, some trauma, extended fasting. So the patient's been fasting, their bile just sits in here, and eventually can actually cause cholecystitis. On this patient here, pericholecystic fluid, unbelievably thick wall. That's the lumen. That's the entire lumen right there, dead center. A lot of edema inside of this wall as well. Interesting. suppurative or emphema. Emphema. I prefer saying suppurative because I think I actually say it correctly. That means pus forming. A fever. If you're creating pus, you probably have some kind of infection. So a fever and the white blood cell count is going to be high. Possibly sepsis. A number of years ago, hospitals had a nationwide initiative to reduce deaths by sepsis. So we started getting calls over the intercom all the time for sepsis alert, and there'd be a whole team. What happens is in the hospital you get code, or sepsis ER, and the whole sepsis team will run down there, and the specialized doctors and nurses to evaluate and help these people. But sepsis is basically the bacteria has overwhelmed the blood and is going all over the body, and obviously that can kill you very quickly. Perforation is another complication of cholecystitis, or peritonitis can be caused. So anytime a fluid goes into the peritoneum, that irritates the peritoneum. You get peritonitis. Sometimes you get fluid in there and it does not irritate it, and then you simply have ascites, whether it's gross ascites or a tiny bit of ascites. But if it bothers the peritoneal lining, it would be more of a peritonitis. Or if it causes an actual infection, then it's definitely a peritonitis. Abscess formation is also possible. So an abscess would be a little more localized. Both of these look like small abscesses to me, or are forming. Fever and sepsis are also a possibility with perforation of the gallbladder. Gangrenous, gangrene, thickened edematous wall, sloughing of dead inner wall. So here, this almost looks like that image the other day of the. All right, it's going to come to me in just a second. The daughter cysts and everything. For God's sakes. Anyway, this is the inner wall is actually peeling away because it's dead, or perhaps the middle of the wall is dead and the inside wall is peeling off. But in any case, hydatid cyst. This kind of looks like a hydatid cyst with daughter cells, but this is peeling off. So sloughing of dead inner wall. Air may be present in the lumen or wall. We don't have any air here. Let's see, we have stones floating in a thick fluid up here, thick sludge here. Stones, tumefactive sludge here, thickened wall. Now, those are hard to, I think this one's a pretty good example of gangrenous. You definitely see that there's dead material here, whereas over here, they call this gangrenous, and I have no reason to doubt it, but all I see is a super thick wall. But yeah. Emphysematous, gas-forming bacterial infection, air in either the wall or the lumen. So look at the dirty shadowing. Dirty shadow, and well, this one's, but that is dirty shadowing. If this were wall echo shadow from stones, this would be black. But since it's not black, we know that it's air. We also know that it's air because we could also see fundus over here with no air, which tells me on this one, the air, I think, is in the lumen. I bet if we roll this person up on their side, the air will obviously move and the dirty shadowing will be in a different location. person also has got other junk inside of their gallbladder, as well as this person. This one, probably in the lumen too, because I'm thinking this person's laying, this is a big gallbladder, person's laying down on their back. This appears to be the high point of the gallbladder, so the air probably trickled all the way up to here. If the air is in the wall, you roll them and the air does not move, but it still has dirty shadowing rather than dark shadows behind it. All right, sorry guys. We actually don't have a lot more. And so I think today's going to be a short lecture. Well, that'll give you time to study and all. But unless I have any objections, you guys can't stand this anymore. I'm just gonna keep going until, because I didn't go through I didn't take notes for the entire chapter. I got up to neoplasms, and I said, you know what, that's kind of a new subject, so I stopped there. And I wasn't sure how bad this would be. I don't think it's too bad today, but could have been worse. All right. Okay, so let's keep moving on. Okay, honestly, this was new for me. Bouveret. If you're French, you'd never pronounce the last word or last letter. Why would you? Bouveret syndrome. See notes below. Well, you know what? I think I'll double check my notes. So X-ray, film, air. So this is no big deal. The stomach's actually pretty large here, and the reason the stomach is large is because there's a blockage. So we do have fluid in the stomach with air up top. Well, this person's standing up, so that's where air would be. So that's not such a big deal. There's supposed to be evidence of air in the liver with these two arrows. Wow, I'm impressed that doctors and other people talented enough to read X-rays, because I can't see it. So this stone supposedly is not sitting in the gallbladder, but is actually sitting in the duodenum. So with Bouveret syndrome, a large stone has perforated through the gallbladder wall and through into the duodenum. So it's created a fistula between the two organs, a fistula being an unnatural opening between two organs. And the stone has gone through and also impacted. So, and by the way, there are no ultrasound images, because no ultrasound images exist of this condition that are worth looking at. Air inside the liver is not normal. Remember, on CT, air is black. We have air following the biliary tracts on this liver. Once again, large stomach here, kind of like Africa. But and then another picture. This one I had a hard time understanding. Am I looking entirely at a stone here? If so, it's not a very bright stone, because stones made of calcium, well, probably not so much calcium as oh, that's right. That is right, guys. On CT, there are some stones that are brilliant on ultrasound. I think the bilirubin pigment stones are very brilliant on ultrasound and invisible on CT. And sometimes stones on CT are not so bright, and depending on what they're made of. So if this is a cholesterol stone, maybe it's just simply not as bright. I don't know enough about CT to say. but supposedly that's what we are seeing here. So that's one example, by the way, of why people will get a CT and an ultrasound sometimes, is that CT will see things that ultrasound can't, and ultrasound will see things that CT cannot. Oh, Merizzi syndrome. Now this one is more, that previous one, just kind of put that in the back of your mind somewhere. The Merizzi syndrome, we put that more towards the front of your mind. That is always a question. Stone impacted in the neck or cystic duct. So here's the gallbladder, there's the stone. So not quite in the gallbladder, but not all the way down here either. It's a double whammy. Compression of the common bile duct, common hepatic duct also occurs. And so what is happening here is not only are we blocked from the gallbladder, but we are blocked here in the liver. So the liver is getting greatly increased intrahepatic ductal dilatation. Just simply means the ducts inside the liver are big. This person is in agony. This person is jaundiced. I probably came in with yellow skin, yellow eyes. Here's another example, a decent sized stone. How that even got out of the gallbladder, I don't know. But this stone sitting here, not very shadowy, but still causing a backup of bile in the liver as well. These people are miserable right now. Porcelain gallbladders, I think I saw one. It wasn't terribly impressive. These are pretty rare. But it can be difficult to differentiate from Wes. So this one, well, if you weren't paying attention, you'd be like, oh, wow, look at that wall echo shadow. But look at this. You're actually getting some posterior wall here. So the sound beam was able to just make it through the gallbladder here. And gosh, it seems to be same echotexture as the liver, kind of like a hepatization, but still, you're able to see posterior wall. If this were all stones, no, everything would be black. So, oh, I'm sorry, I didn't even really explain what porcelain is. That would be helpful, I guess. Porcelain gallbladders are from chronic, repeated attacks of cholecystitis. Over time, the wall calcifies, and so this is why you could see it on X-ray. I think it's so painful, it's actually caused scoliosis in this person, that their spine is actually trying to get away from it. I'm kidding, that's not what happened. But you can see them on X-ray, and that's a nice, pretty picture. And from here, you can see that's clearly not the wall echo shadow because we're seeing gallbladder behind it. Porcelain gallbladders. Gosh. So I just have a couple of other notes. I just want to make sure. Let's see. So I failed to mention, really the difference between acute and chronic. Acute cholecystitis is, oh my God, what's going on? And you go in and you have this gigantic gallbladder, and the wall is thick, and there's a stone impacted, and it's a medical emergency. Chronic cholecystitis is a little confusing because they say that cholecystitis is when the stone is stuck in the neck or in the wall. And I've had plenty of people with chronic cholecystitis. They get attacks once a month, once 6 months, couple of years apart, they'll get an attack and they'll know it. It'll wake them up in the middle of the night usually, which is really fun because then they wake you up in the middle of the night and ask you to come in to look at them. But so these people, invariably when I see them, there's not a stone stuck in the neck or in the cystic duct, but yet they still have stones and they still have thickened walls. And some people are totally and absolutely asymptomatic. And that I found quite a few stones on people who had no idea that there was a problem. So gallbladder wall thickness in general, I mentioned the other day, anything over 3 millimeters is thick. And that's usually from cholecystitis, but also infections. Adenomyomatosis is, oh, well, good grief. We actually have an evidence of, I didn't even plan on that. Adenomyomatosis, evidence of it right here. We'll talk about this, I guess, tomorrow. Oh, no. Probably more like Monday. But in any case, cholesterol crystals get stuck up in the wall, cause these little ring down artifacts, and it can thicken the wall, but usually does not cause more problems than that. So it's a self-limiting disease. And of course, carcinoma of the gallbladder would obviously thicken the wall. But caliper placement on this one, just measure the whole thing. Over here, you just, that's all you see is an echogenic line. You measure the whole thing, clearly measure the whole thing. Over here, I'm not going to measure the echogenic portion. I'm only going to measure this little hypoechoic wall over here. Yeah. This is new. I was actually looking, you know what I was looking for and I couldn't believe I had a hard time finding it. Stones are probably sitting on invisible sludge because, God, they're right in a line here. And they called it floating stones, but stones, they almost have to be laying on something to be floating like that. So I imagine there's actually some invisible sludge, just slightly thicker than the bile up here. And that's what these stones are actually sitting on. That's a really cool picture. And this is just an example of gravel. Actually, this is the greatest movie of all time. One of the greatest movies of all time. And just another picture of a gallbladder. Let's see the wall. Yeah, see, I don't know where to put my calipers up here, and I barely know where to put my calipers back here. So, but nice fluid level. These stones are more dense than the more dense than the sludge, so they've sunken down and are laying down. And here's just one image of stones, and I just thought that was really interesting how they can develop. They look like Dungeons and Dragons dice or something. They're probably form like that because they're up against each other, constantly rubbing against each other and kind of creating these little things. But anyway, I think that was my last yes. Okay. Sure, we don't need to record the rest of this.